3100%. Active queue. Matthew's MacBook Air.
Okay. So do we have everyone in? And we are streaming. Good morning and welcome to the Health and Government Operations Insurance and Pharmaceuticals Subcommittee. We know this is an unusual day for us to be having a hearing, to having a work session, but we're really committed to completing the work on HB 123, which is our telehealth bill. And today, the process that we're going to follow is we're going to continue to work through the draft that we had on Tuesday. And but please know that we are already considering changes based on the comments that we heard on Tuesday. So what you will see next Tuesday will be in response to the comments that we have had, and we've tried to address some issues and that people identified in the first 6 pages of the bill, or the first 5 pages of the bill. So we are listening. We are trying to take that into consideration. We're working with advocates in the meantime between these sessions so that we can see if we can come to language that everyone feels comfortable with. So we'd like to continue with this process. And so we're literally going page by page. If you have an issue on a page or you have a question on a page, please use the raise hand function so that I can call on you. So we are going to start. And Brigida, would you let Rachel and Evan Hoffman in? Thanks. We're going to start on page 6, which is where we left off. And Lisa, do you want to talk about what's different in this reprint on page 6?
So what we were discussing on Tuesday was adding in the fiscal year limitation for both audio only or audio visual healthcare services, and then also adding in some Medicare language, Medicare guidance language that would specify when a telehealth or an audio only, I guess, telephone conversation would not be considered telehealth.
Okay. So in some of the conversations that we've heard on Tuesday and since then, we're understanding, Lisa and I are understanding that the lines 18 and 19, the issue with adding audiovisual telehealth there is because this language could potentially diminish the kind of telehealth that was being done before the pandemic. We didn't ever have that intention. So we are going to take the audiovisual part out of that part of the law, or that part of the statute. And with respect to defining audio only, this language that we were talking about came from CMS. I would like to offer to you all now, not to be confirmed, but for consideration, and you can give us some information, either, electronically or when we meet again on Tuesday, because we will take this bill up again on Tuesday. We understand that the major concerns are the time limit and the leading to the fee for service requirements. So what I was wondering and would like to offer to you is if we can define audio only as a call in which the patient has arranged an appointment and it leads to a billable service, or it includes a billable service. So we would remove the 5 to 10 minute conversation. We'd remove the originated from the healthcare provider, and we'd remove leads to in-person or fee for service. So this makes it clear that it is an appointment that's arranged by the patient and that a billable service is delivered. So again, for your consideration. And we'll talk, I don't want to, people don't need to respond now because you need to see whether or not that meets the needs. But on Tuesday, we hope that you have some feedback on that. Everyone understand where we're kind of going with that? The other piece is the electronic email and facsimile that would stay in there, of course. Any questions, other thoughts on page 6? Okay. We're going to page 8, and I think Lisa, you had a question on page 8.
So it's page 5 of 8 of the bill. Page 8 of the reprint is reinserting language from 15105.2b, which requires that if MDH specifies regulations, the types of healthcare providers are receive Medicaid reimbursement for telehealth services, it must include primary care providers, psychiatrists, and psychiatric nurse practitioners. And this language is expanding on the previous language, as was done in House Bill 551, to also require MDH to include providers who are licensed, certified, or otherwise authorized to provide mental health or substance use disorders. And it goes on, it specifies mental health and substance use disorder programs. And I had a question just for clarity purposes, just of why this is so specific to these providers. I'm just curious, is this something that is being excluded now? That's probably a question for Lori or Ellen.
So Ellen, did you want to take a stab at it?
Yes, be happy to. Under current law, these specific providers, licensed practitioners for mental health and substance use services, as well as licensed programs, are not included in the specific provider types that must be reimbursed for telehealth if the department decides to develop regulations on this. And so we thought very important, given the dramatic need for mental health and substance use care as a result of the pandemic, and because of the high utilization of telehealth by mental health and substance use disorder providers and practitioners throughout this pandemic and will be post-pandemic, we thought it was essential to articulate the inclusion of these providers as well. So that was the reason for setting it out with that specificity. It's not right now articulated in the law, and we know that the utilization has been in this particular area.
Laura, did you want to have something else?
No, just to add, I guess that when the state of emergency came in, the governor allowed us the flexibility to use our paraprofessionals, peers, et cetera, to provide psych rehab and other services, and it's been a real godsend. So I think that was the impetus behind, wanting to keep this in the bill.
And would that concern be addressed by the bill that that Delegate Kelly's bill that we passed, that the committee passed regarding removing the sunset?
No, that's specific to prescribers on ACT teams. So it wouldn't necessarily apply to other members of ACT teams or other members of other services that are not clinicians.
So let me ask committee, if you've got questions, and I don't mean to monopolize, so please, feel free to raise your hand and let me know. Let me ask if you feel like we could meet this need by make sure that all licensed providers, certified and otherwise authorized under the health occupations article, period. If that would, then we would include also, which would include primary care providers, psychiatrists and psychiatric nurse practitioners, and mental health and substance use disorder programs. If we had just those elements, wouldn't that include everyone? Here's the reason I'm asking this question is because there's some concerns that when you begin to list specific people, you exclude others. So if we can, we would continue to include primary care because that's a really important group of providers. We'd continue the mental health folks specifically in a more general way, and both the practitioners and the programs. would that meet the needs of this section?
So Madam Chair, you're suggesting keeping numbers 3 and 4 and eliminating the other portions?
No, I would keep, I'd keep 1, I'd keep 2, 3, and 4. But in 3, I would put a period after article, after the word article. And I'd make that number 1.
And then primary care providers would not be there, or you would
Yep.
also retain primary care providers
would
in
retain-
addition?
Retain primary care, right?
And then all other licensed all other entities licensed or certified under health occupations. And then keeping in current for the programs, mental health and
Correct.
substance use. Okay,
Okay?
Yep.
Any other questions on, thank you all. Thanks for working through that with us. Any other
The-
questions on page 8? Oh, sorry.
I'm
No?
sorry, Delegate Cullison, the subsection, we now go to D3, and D3, again, I don't want to jump the gun here, but D3 obviously incorporates by reference some of those D2s. So I don't know what you're thinking about in terms of D3, but I guess we may need to discuss that as well.
Do we need D3 if we replace it with D, if everyone is covered under D2?
Madam Chairman,
Delegate Saab?
I'm sorry, I came in, I did a little switch between my phone and then, do we have I don't have a copy of the amendment. Was a copy sent to my office?
Is
It's
this
the same one we were using on Tuesday, Delegate Saab.
right?
Okay, all right, so,
Right.
okay, so nothing, okay, that's good, thank you.
So Delegate Cullison, that D3 in this version is very important because it is the provision that speaks to payment parity, payment for these services at the same rate as in-person services. And so, yes, in our view, it is essential to articulate that in this Medicaid provision.
Okay. Okay. So to be clear then, that payment parity as we currently have it as the result of the emergency legislation would continue through the course of the study. Okay. I mean, I mean, unless it's payment parity, and make sure that I understand that if it's payment parity for fee for service, that would continue forever. But yeah, I'm not being very clear. I'm sorry. I just want to make sure that we're not locking ourselves into something long-term before we've studied. So it works for now, absolutely, but that's my intent, is to maintain. And just so you know, I have been informed that the Medicaid rate of reimbursement increased 7% after April 30th. So we will be taking out the reference to the date because nobody told me that, folks. And so we do not want to go backwards. We want to go forwards with this. So does that make sense, Ellen? Okay, if payment parity is, we need that, we can keep that.
Thank you. And again, because these provisions were incorporated from 551, which was focusing very specifically on mental health and substance use services, we obviously were saying in that bill, payment parity applies to those services that are being delivered by mental health practitioners and programs. And so that's essential. Obviously, there are now somatic services that obviously are addressed by 123. But we're making very clear in 551 that same reimbursement rate must apply for audio only and audio visual, the same in-person rate for mental health and substance use services.
Got it.
And
Okay.
thank you for taking out that date. We truly appreciate that.
Okay, thanks. Okay, let's move to page 9 from line 20. And Lisa, I think we're probably going to have to take out the audio visual piece here as well.
Mhm.
Okay. Okay. Okay, any questions on page 9? Okay, we're going to go to page 10 and then page 10, we have another.
Madam Chair.
Oh.
Matthew has a question.
Oh, I'm sorry. Matt.
Thank you, Delegate Carlson. The commercial carriers have a couple of issues with bottom of handwritten page 9.
Okay.
Mostly having to do with remote patient monitoring and store and forward communications.
Okay.
This was discussed through the 5 MHCC work groups in the Medicaid space. It was discussed in the stakeholder meetings. It was never discussed ever in the commercial market space. We don't think it's appropriate to bring this over for a couple of different reasons. For the commercial carriers, when we discuss remote patient monitoring, most of it is durable medical equipment. And if we're going to include it, we need a really tight definition because, as we know, for the duration until the sunset, things will be billed at parity with in-person visits. So if you take your blood pressure once, or if you weigh yourself, that should not be billed at the same rate as an in-person visit. This is why we never had these discussions whatsoever. Also, we don't see remote patient monitoring as telehealth. Telehealth is an interaction between two parties with an analysis. We don't think this is appropriate for this section, but we do feel that there is more remote patient monitoring being used as we move forward. The technology is improving. And we think that the remote patient monitoring and store and forward in the commercial portion of the bill would be very much appropriate for the study. I don't know exactly where it should fit into the study language, but I think it would be something that we should not get ahead of our skis on and make sure we understand the impact before we put it into this bill.
So Matt, let me ask a question. So it's not currently being covered, is that right?
No, remote patient monitoring in some instances is being covered carrier to carrier, but it is not a blanket sort of statement. And like I said, it is more in the durable medical equipment space. We don't really look at it as telehealth. We look at it as something that's different.
Okay, so
drafted, we pay parity like an office visit for remote patient monitoring, and we don't think that's appropriate.
let me go back to Lori or Ellen. In the mental health space, I think this was an important piece. Am I remembering correctly? Is it currently being covered in the mental health space now, the remote patient monitoring?
It is not. So we are actually using remote patient monitoring in our organizations, particularly around medication adherence. But right now, because the regulations around remote patient monitoring are restricted to only 3 diagnostic categories, COPD, congestive heart failure, and diabetes, behavioral health has not been allowed to be part of that discussion, which is why we were so interested in looking at ways to start the use of remote patient monitoring, particularly in behavioral health, because of our workforce crisis and other challenges that we're facing.
Okay. So if it's not being covered now, it could definitely be a part of the study, and that would be, you'd be able to make that case. Thank you. Jennifer Whitten, there you are.
Thank you, Delegate. Appreciate that. I actually had raised my hand just to
Sorry.
point out, no, it's okay. Point out on page 9, the definition under telehealth as it relates to the insurance article. I want to make sure we're being consistent because under the program, we're specific about somatic, dental, and behavioral health services. And here we say somatic and mental health services. So just pointing out, and perhaps that's been fixed, but want to make sure we're consistent there. And then as it relates to remote patient monitoring, this is something, I think Lori said it well. Medicaid is currently covering some remote patient monitoring applications for certain patients who have either been hospitalized or have certain conditions. And our members have had a lot of value in terms of using this technology. There is a definition on page 4 that kind of outlines sort of, this is a national definition that's used on what those services are. So just wanted to point that out to the committee, that in the program, that's the way they define the use of that technology.
Great, thank you. And let me go back to Jen on line 29. So are you saying we left out dental? Is that what we left out?
Yeah, I mean, I think for consistency, we would want to just make sure it's the same, that it would be somatic, dental, and behavioral health services. And that way we're being consistent between the insurance article and Medicaid. But Lisa, my apologies if I don't have the reprint with the handwriting on it.
Okay, we'll check that out. Thanks. Ellen?
And so, thank you, Delegate Cullison. Along those same lines, on line 29, somatic and mental health care services, again, dental needs to be included, but substance use disorders should also be included in that as well. And I think we prefer both mental health and substance use disorder language rather than behavioral health to cover both mental health and substance use disorder. So there is a reference to substance use disorder counseling on page 10 that we also wanted to reference. So there is a little bit of a disconnect between the definition of telehealth and then a separate provision that actually says that substance use counseling should be included. So we think we can clean that up by including substance use disorder care in the definition of telehealth.
Okay, we'll look at that and see what effect it has on the bill.
Thank
Matt?
you.
Thank you, Delegate Coulson. I just wanted to chime back in. Some of the advocates sort of made my point for me, I think, is that on the remote patient monitoring section is that it's been in Medicaid in limited circumstances, but it is expanding. That's exactly why we think it's appropriate for the study. It's limited now, but it's really so much. I mean, it's emerging just like everything else that incorporates any of these new technologies, but we don't know what the impact is yet. And I think that's exactly why it's a perfect place for the study to look at, because I think we're going to be using these technologies as we move forward, but we don't know how it's going to work now. We don't know, the rate certainly shouldn't be equal to an in-person visit for some things and others. And the way it's written now, it's really broad.
Appreciate that, thanks. Kim Robinson.
Good morning, Delegate Collison and members of the subcommittee. Just wanted to add a little bit to what Matt shared about remote patient monitoring. It is, I think, a little bit more complex. And I think one of the challenges is the way that this law is fashioned by adding it specifically to the definition of telehealth, and then telehealth being defined specifically for purposes of payment parity, is really taking where the reimbursement exists and matching it inappropriately. So it's not the same as an in-office visit, and it doesn't necessarily match directly to an in-person service. There's a lot about remote patient monitoring that's going to be unique to remote patient monitoring. And so I think your conversation about why we need to better understand it, why there's been limited coverage of it, through the Medicaid program and under the federal government, and why it is growing with carriers, but it's still growing with carriers, is because we're working to make sure that the technology that's associated with it is quality. There's a lot of evidence. If you were to just simply Google remote patient monitoring, there's lots of little companies that are trying to jump in this space, but we always want to be sure that if we're going to be covering, a particular device, that it's going to be high quality, it's going to take good data, it's going to give the right metrics so that it's useful for that patient and the provider. And so we are a little concerned with the structure of this bill, pushing it forward quite this way. I think it's absolutely appropriate for the discussion within the study. And I do think that it's one of those spaces where we're going to see a lot of evolution in a short period of time, but it's at the beginning of that evolution.
I appreciate that. Okay, thank you all. So I think we've covered page 9. We're gonna head to page 10. Lisa, changes on page 10. That's the definition of audio only, which we've already spoken about. Okay, I think
The
regardless.
only other change is that it clarifies that coverage is required to be provided regardless of the location of the patient at the time the telehealth services are provided. And that was also a part of House Bill 551.
Okay. Any questions on page 10? Kim? Kim, did you have a question on page 10 or is your hand still up?
Hand is still up. I'll take it
Okay.
down. My bad.
Okay, Ellen? Page 10.
Yep. Thanks, Delegate Cullison. This is the area, line 21 and 22. This is where the private insurance code already identifies that healthcare services appropriately delivered through telehealth shall include counseling for substance use disorders. In 551, we made a small amendment that said counseling and treatment for substance use disorders. And so that's a clarification that we would request be added in there.
I don't know, that's a very big ask, Ellen. Okay, I think we can do that.
Thank you very much.
Okay. All right, that takes care of page 10. On to page 11.
Delegate Carlson, I have a comment, but I don't have a hand raising function on page 11.
Hi, Allison. Okay.
Okay. This relates to the new subsection H that that's in line 23 there. The H1 requires a carrier to allow an insured patient to select the manner in which a healthcare service is delivered. My concern with this is that it removes the role of the provider from having a say in how a service is delivered. And it kind of inserts the carrier into that. I gave this example to some of you when I was talking to you privately about this, but one good example is I had a OB appointment yesterday. I had asked my doctor if we could do it by telehealth because session is busy. The doctor said, no, this is when you have to come in for. So, if I had wanted to fight them on that for whatever reason, does the carrier have to demand that the physician see me by telehealth? I don't understand what role the carrier would play here, and think that the provider should have an important role in determining where the service is delivered to. So that's my concern.
Okay. Let us think about that and see if there's a way to, do you have a suggestion about allowing the patient to have some say, but at the same time, making sure that there's a balance in terms of how services are delivered?
I would recommend just taking it out. I don't know what it would add over H2. And this is not something that Kaiser has gotten involved in doing. I don't think any of the other carriers have either. So I don't know that there's a problem here that really needs solving. But of course, open to suggestions from others on that.
Okay. All right, so I saw Ellen's hand first.
Oh, thank you, Delegate Cullison. A few points about that, and then there was something else on 11 after others weigh in on Allison's point, I think.
Okay.
Again, we think that there is a real need for consumer choice on this, and that their continued ability to be able to identify the way in which their care is delivered. That obviously will be in conjunction with conversations with their provider. We don't think that that is we think that's the way it always and should work. We just do not want it to be taken out of the hands of consumers. Consumer choice is associated with satisfaction of care, retention in care. And right now, with the expansion of telehealth, we think that is essential in order to be able to ensure that a consumer's voice is heard on that. So I know others will have other things to say, and I just would like to come back later on one other point on page 11, please.
Okay. Robin?
I think Allison raised a good question. I think we can find the answer in the Health Occupations Code.
Okay.
In the legislation that you all passed in 2020 that applies to anyone licensed, certified, or authorized under the Health Occupations Code, that they must make the determination about whether or not a certain mode of communication is appropriate. So the health professional is absolutely obligated to ensure that whether it is a audio only, an in-person, a audio visual, or some other form of communication we can't even envision in the future, that provider is clinically, ethically, and legally responsible for determining if it's appropriate.
Okay, thanks. Anne, Seacott?
Thank you, Madam Chair. I think that we could probably find some language in here if we need to, that sort of, as Robin was suggesting, in some ways, include clinical appropriateness. I think it's something that we want to make sure. We've just heard so many stories from people, on both sides of this issue of the use of telehealth. They loved it. It was great. It was something they really needed. For other people, oh my God, they hate it. They hope they can't wait for it not to do it again. So just taking into account the consumer piece of it, the consumer position of this, but absolutely within the context of that it being appropriate.
Okay. Thanks. Laura Mitchell?
Yes, thank you. As a consumer, I absolutely advocate for keeping this in consultation with my provider, absolutely. And as clinically appropriate, absolutely. But for someone to be able to tell me that I have to take this telemed visit because I can't get a provider close to me, that's unacceptable. It has to be my choice. Sometimes I'm comfortable with telemed, sometimes I need an in-person. And same thing for family members. It has to be the consumer's choice.
Okay. Thank you. Kim Robinson?
Thank you, Delegate Collison. I think that there's something being conflated a little bit. This language here is speaking about insurance coverage. And I think that the conversation, and I think Robin made an excellent point, that in terms of the role of the provider and that already being spelled out in Maryland's law, that ultimately, while consumer preference, where there is an appropriate choice to be made, should be respected, ultimately the clinical decision of a provider where it's not appropriate for telemedicine is what has to take precedence, right? And that's addressed through providers, through health occupations. This provision is talking about speaking to carriers about when carriers are essentially able to say this telehealth visit did or did not comply with our coverage decisions and with the law. And I think to Allison's point, if you look at H2, which simply says, and very clearly says, a carrier can't say that you must see someone in person as opposed to telehealth, period, I think from a coverage perspective is very, very clear. I think the provision before, where it talks about placing some judgment on what the insured preferred, that's not even reflected in a claim. I don't even know how a carrier would know that one way or the other. When you're speaking to carriers, what you want to say to us is, as long as it was clinically appropriate, that's to be delivered by telehealth, that's the only thing you're allowed to care about. So as long as the service was appropriate for telehealth, it is absolutely then the patient's choice which way they got it. I don't know how a carrier is even assessing that for that to be, you know, what the concern is. I think the language that's in H2 is very clear for carriers and doesn't create that question of exactly where in the claim are we now checking for what the insured's choice was, because at that point, the service has already been rendered. And if they wanted telemedicine and the provider wouldn't let them have it, that's a different discussion between the provider and the patient. That's not really about the carrier. So I think that the language that's in H2 stands alone very effectively.
So just, so if I could say it in one sentence, Kim, it's like, there's no pre-authorization for the type of treatment, right, by a carrier.
Right.
Okay. Okay. So we're just talking about this section right now, section H. Laura. So I see. So Robin, are you still on that section?
Oh, I meant to lower my hand, but I would just maybe, since I'm on, add that if we decide that we want to recommend anything on this area, you know, I think it's really important not to create a new provision around determining what's clinically appropriate, but rather we really want to keep the governance of health occupations under the health occupations code.
Great.
And so I'm not sure what the ultimate solution is here, but just wanted to urge not creating kind of a double standard on what's considered clinically appropriate and keep that in health ocs.
Okay.
I agree. I think that makes perfect sense, Robin.
Okay. Laura, did you have another comment on this?
I do. In terms of, no, you don't have to pre-authorize the mode of delivery, except when you are trying to find an appropriate provider and there isn't one close to you. So you have to ask for a single case agreement or out of network payment. And for them to say, no, we won't cover the out of network payment because we have this telehealth visit appointment. If a telehealth appointment is not my preference or not appropriate for me, in my opinion, then they are forcing me they are taking away my choice by saying you can pay out of pocket and take this or take the telehealth. So this would eliminate that opportunity.
Thank you. We can take that into consideration. So I know, Ellen, you had something else, but before I go to Ellen, Evan Hoffman wants to make us comment on the remote patient monitoring piece. Correct, Evan?
Yeah, hi, Delegate Collison. Sorry about this. I just couldn't figure out how to raise my hand earlier and missed the opportunity to jump in. Okay, so Phillips, we've been advising legislators on remote patient monitoring services across the country. And I just want to share a few reactions just because this is a really important topic for patient care in Maryland. I'll say that remote patient monitoring is widely viewed as a telehealth modality. So just for example, the Center for Connected Health Policy, which is a well-known national organization advising policymakers on telehealth, do view RPM as a telehealth modality, just like they view asynchronous and synchronous care as well. And the Center for Medicaid and Medicare Services started to issue reimbursement codes for RPM in the last 2 years. So if you are a Medicare beneficiary, under certain circumstances, you do have access to RPM right now. It's not uncommon for states to require commercial payers to cover RPM. We're seeing this in Virginia, Colorado, Massachusetts, and a variety of other states. But I do agree that there isn't really a comparable in-person remote patient monitoring situation. So payment parity might not be the right place to put it. It's in states where we are seeing it, we're seeing payers have the ability to, the opportunity to negotiate directly with providers on a payment plan that makes sense. But I just wanted to offer a few other places of comment for RPM because we are seeing it for a variety of use cases around patients to help deliver patient care if the provider views it as an acceptable form of treatment.
Great, thank you very much. And Ellen, I'm coming back to you. You said you had something else on page 11.
Yes, thank you, Delegate Collison. And just, what I wanted also to do was to, Laura said it perfectly in terms of why this consent issue in H1 is in fact an insurance access issue. It is not just with regard to, service, sort of the delivery of care that belongs in health occupations. Our, 15-803, 830 does allow patients to request an out-of-network service to the extent in-network services are not available within a reasonable time and distance. And to the extent that this consent provision is removed and that carriers can require patients to take a telehealth service because it is perhaps available where an in-person visit is not, this will clearly affect consumers' insurance rights. And so that's one of the reasons we put that in 551, because the network adequacy issues are huge for mental health and substance use providers in private insurance. And so this will, again, retain existing rights that exist under our network adequacy standard and existing rights that exist in 15-830. So for those reasons, it's very much relevant to insurance, and it's very necessary in our view to retain it. And then the other issue that I wanted to raise on page 11 is, again, a provision that was in 551 was, again, a requirement that the carriers use, now I'm talking about the Parity Act, the Mental Health Parity and Addiction Equity Act, that their utilization management requirements be compliant with the Mental Health Parity and Addiction Equity Act. And there's a provision in 551 that would have modified the language on page 11, lines 17 through 20 to ensure that that was reinforced. So it goes to your question, Delegate Cullison, what are the utilization management requirements for getting a telehealth service? We want to make sure that all of those utilization management requirements are comparable for mental health and substance use services to what is required in somatic care.
Okay.
Thank you.
Thank you. And I saw Kim Robinson's hand.
So Delegate Collison,
Yeah.
I don't know. I guess there's no circumstance under which I read anything about this provision to undermine or undo the requirements of 15830, right? So this doesn't supersede that or create a new paradigm that doesn't still make the same requirements that if a patient can't receive the care without undue time or travel, that the requirements on carriers for how that is to be covered still exists. And again, the language that is present in this bill in H2, where it says that a carrier can't require that someone receive their care by telehealth, in lieu, maybe what I'm hearing is what the advocates are saying is they don't want it to say to read that a carrier can require that a patient receive their care in office in lieu of telehealth or by telehealth in lieu of an office if clinically appropriate. I think that's different than what's being said in H1. Again, I think the language in H1 is more so around the clinical appropriateness and the judgment of the provider and who is ultimately making that decision. Is it the patient or the provider who's determining the clinical appropriateness of a telehealth visit? I understand if what the actual request is to say that carriers aren't able to mandate what is beyond it being based on clinical appropriateness, that a patient receive care either in office or by telehealth. I don't think that 1 and 2 are saying the converse of each other. I think they're saying two very different things. And I think that's why H1 is creating the concern. And I appreciate the comment from the gentleman from Phillips around remote patient monitoring. I think when I say it's not telehealth, it's not that it's not, electronic and telehealth, big telehealth in the context of what telehealth means in this statute. And his very specific point, I think actually concurring with me, that it doesn't necessarily fit from a parity provision because it's not a one-to-one with in-office services. Here, defining it in telehealth this way with all the other associated provisions is why it's a concern. So thank you. And I'll be quiet now because unfortunately I need to leave for another meeting, but thank you.
Thank you, Kim. Thanks for being here. Just to be clear, anything that's currently covered by remote patient monitoring will continue to be currently covered under the bill. And we're gonna, study the heck out of it and see how we can better use it going forward. So, just want people to know we're not in any way diminishing any services. If that's all on page 11, we'll go to page 12. And here's where that date is a problem. Another place where that date is a problem. And basically what we have to consider is how to word this so that whatever was in place as the result of the pandemic, right? So the emergency requirements within 2020 throughout the year are maintained going forward through the period of time of the study. So just know that if you've got language that you think addresses that, please let us know, but that's what we're going to be working on to figure out how to say that. Is there anything else on page 12 that people?
Madam Chair, I just have a quick question. I don't have a raised hand. Can you tell me why that language doesn't work? Like what have been the concerns you've heard? I'm assuming you're talking about A and B at the top of page 12.
Right. Because the Medicaid rate of reimbursement increased 7% between April 3rd and January 1st, 2021.
Okay, this is in the insurance code. So that's why I think I was a little confused.
Yeah, okay.
There's a cross-reference in the bill that applies this to Medicaid. So it's possible when I go back and change things, which I haven't done yet, that I'm not sure, maybe the date could stay for private insurance, but not stay for Medicaid. I haven't quite figured that out yet, but that was.
Okay, I just didn't know why. Thank you.
Okay. On page 12, we just reaffirmed the
I think
authority.
Ellen has something else she wanted to say.
Oh, I'm sorry. Ellen, on that issue?
Yes, just something that Kim just mentioned, that Lisa just mentioned. There are concerns in the private insurance context as well about attaching a date to reimbursement rates. And the concern for mental health and substance use disorder services is that we don't know what the rate was that was reimbursed on April 3rd by any particular carrier. And as you all know, we have this, again, separate Mental Health Parity Act concern, and it's been raised a lot with regard to reimbursement, that the reimbursement rate for mental health and substance use services may in fact not be comparable to the way the rate was set for medical surgical services. And so to attach a date means that we could be baking in a discriminatory rate setting standard for mental health and substance use services by attaching a date to it. So that's the independent concern with regard to a date for a private insurance that is very much separate from that 7.5% rate increase in the Medicaid context.
We get it.
Thank you.
Okay, seeing no other hands. Anything else on page 12?
Excuse me, Chairman Collison, it's Kathleen Loughran, and I'm sorry, I don't have a hand on
You don't have
my
any-
screen. No, I don't, unfortunately, but thank you. And thank you again for the opportunity. I have general concerns, I think, as you've heard in the past, with mixing and matching the insurance article and the Medicaid statute. We have provisions in this bill that are drawn directly to the Medicaid statute. So if there are provisions, other provisions that ought to apply to Medicaid, those provisions should be in the Medicaid statute. It is not a good idea to continue the habit of cross-referencing insurance article provisions to the Medicaid program, because all too often we see down the road there are problems when individuals are looking in the commercial market and looking to make changes that are not pertinent to Medicaid or not appropriate for Medicaid. So I guess I would ask, because we have a Medicaid section and a commercial section in this bill, Anything you want in Medicaid should be in Medicaid. There's no need to have a cross-reference here.
Okay, let us take
I
that.
know that's more work, unfortunately, for Lisa perhaps in drafting, but I thought it was important to raise.
There's also something to keep in mind. I think the cross-reference right now is just to that sunsetted provision, but we can.
Okay.
Yeah, we'll.
Yeah, I didn't think there was much outside the sunset than that, but because of this recent discussion, I thought we should just take another look. Thank you.
Thank you, Kathleen. Ellen?
Thank you, Delegate Coulson. This is just a really small point on page 12. It's in the uncodified language. In section 4, this is line 32, where it would retain section 3 remain in effect until June 30th, 2025. I think that section relates to the study that was supposed to be performed to see whether it's appropriate for substance use disorder services, telehealth services to be delivered in the home. And if the bill would now authorize telehealth services, you know, wherever the patient is located, then we think that study is no longer needed.
That study's repealed right above that.
Yeah.
The study is bracketed out right above that.
Right.
Correct. But then if you look at, my question then is why in section 32, and maybe I'm reading this wrong, why is section 3 again reinserted as remaining in effect?
It's a draft. Can we just take this offline and we'll figure it out?
Perfect.
Yeah.
Thank you.
Okay.
Thank you very much.
Thank you, Lisa. Thank you, Ellen. Lori?
Thank you, Delegate Coulson. Just one more comment on the rate, date, et cetera. That when you all passed minimum wage, you included in Medicaid rate increases up through 2026. So just also want to make the point that no matter what date we pick, as things go forward, if those rate increases take place, there will be a difference between what is paid for telehealth and what is paid for in-person moving forward.
Right. We're going to figure out the language that allows it to go up appropriately over the course of the study. It'll take some thinking, but we're going to figure it out. Okay, anything else on page 12? Okay. And then page 13, there are no changes on page 13 from the draft we had before. Lori, did you have a question, another question on 13, Lori, or no? Okay.
So can I just add a couple on page 13, just so everyone knows, there are a few changes from the prior.
Oops, I lied.
They're the same as Tuesday, but just it clarifies that the Healthcare Commission will consult rather than, there was other language there, but consult as necessary with MIA and HSCRC, and this is adding in MDH for purposes of whatever the study will do with Medicaid.
Okay.
And then also Lori, I think it was, had requested that the study make sure that it included the use of remote patient monitoring. So that part was included too.
Right. So we do have it there. Okay. Ellen?
Thank you very much. These are not requests that we've made yet, but would you entertain just a little bit of additional language around the study? We thought that there may be a few additions that, again, has been previously raised, would pull in consumer views on effectiveness, as well as identify some of the items within the research literature that recognizes the value of audiovisual and audio only. And we thought we would suggest adding that into the language if you would accept that.
So are you adding research, or are you adding surveys? What did you have a thought about that?
Yeah, I can give you some specifics on page. So we're on page 14. The D3 provision. For example, D3 little 1. We think it's important to consider patient retention rates and reductions in barriers to care. The research literature talks about that in addition to just comparison with in-person visits. And we think that's a really important component.
Okay, say that again, please. Patient retention?
Correct. Patient retention rates
And
reduced barriers to care.
Reduced.
Ellen, can you send something?
Absolutely. That's what I'd be happy to send all this to you.
Okay, great.
Thank you very much.
Anything else on page 13, page 14? These are basically outlining the study. Anything else on those two pages?
So Lisa, help me. Sorry, guys. I don't remember if it's in here. I've been trying to frantically search. I think this is something that I raised last time that I'm hoping is still in the study, because I certainly don't want to add something that's not necessary. But I think there has to be some kind of analysis similar to what Ellen was just saying, that we want to make sure that there's no barriers to people getting the care they need. We also want to look at these to make sure we are not increasing services, like that these services become additive services as opposed to services that are taking the place of, because they're the same quality of an existing service. Because if that's what's happening, then all we're doing is adding services for no value. And so Lisa, I don't know if you recall, if it may have been in the MHCC amendments that's in here, but I think that's an important element to look at. That's been in a number of the literature that has been coming out recently in Health Affairs and other articles that said that's a concern that needs to be reviewed. I'm happy to send you that literature, but I think it has to be part of the study just to make it look at it.
We can look at that. I'm sorry, Lisa, go ahead.
Oh, no, I was just going to say, I'm happy to go back and check. I'm not sure if it's had it. The healthcare study on the alignment of telehealth with new models of care that addresses healthcare services for which telehealth can substitute for in-person care while maintaining the standard of care. I'm not sure if that's the language you were looking for. I mean,
it might be.
We tried to incorporate everything that MHCC had originally had in their amendments, but we can go through that.
And my sense, Debbie, is that that the study itself is going to point that out. I mean, you're going to see what the increase has been and what it's for. So, but that language I think will help get to what you're asking for. I'm going to go to Ben Steffen. Ben. Okay. There you are.
And you're muted.
And you're muted,
Ben.
There you go.
Sorry, this is observation only. But I think the three key areas that we want to study are access, cost, and outcomes. And the more specificity we put in, which in many cases is not what, but how, the more costs we're going to add to the study. We are concerned that we'll all agree on something, but when we put a price tag on it, because of the modes that are specified, surveys, for example, or this particular aspect, without looking at the study in its totality, that we end up with something that's unaffordable. So I just appeal to everyone to not add so much specificity that it's a study that we can't afford to do.
Understood. Thank you. Jen Whitten.
Yeah, just real quick. There is a section that was added to Deb's point around looking at the comparative effectiveness of telehealth and in-person visits on the total cost of care and patient outcomes of care. I don't know that gets exactly to what Deb's speaking to, but I do agree.
Yeah, that's good enough.
Yeah, so I think that was good language that was added.
Thanks,
Great.
Jen.
Thanks. Robin? Oh, mute. You're on mute.
There you go. Just piggybacking off of all of that. I mean, we could see some increase in the number of services provided, and and that could be a good thing. So additive isn't always bad when we're thinking about some of the preventative services and doing more with chronic disease management. And so I think what we're really looking for, this is circling back to what Jen said, is perhaps some visits go up, but we're looking for better health outcomes and perhaps some of the more expensive visits going down. So
I appreciate that. Thank you, Robin. Thanks. And Ellen?
Thank you. Thanks, Delegate Collison. I did not have another comment on the study. There was one other uncodified section that had been in 551 that I wanted to mention.
Okay. Tell us about it now.
Thank you. It was just an issue going back to the Mental Health Parity Act. We did have an uncodified section asking that MDH look at provisions that are not comparable in the telehealth field between mental health and substance use services and somatic services. I had mentioned one last week that there is an explicit prior authorization requirement for all mental health and substance use disorder telehealth. That is not applied, which is in regulation or statute. That does not apply at all to the somatic side. And that's, again, a parity violation. So we wanted the department to take a close look at that and resolve those problems.
Okay.
Thank you.
We could potentially do that outside of this bill. So, I mean, I would think we can do that outside of this bill. Delegate Saab.
Thank you, Madam Chairman. I just had a quick, I wasn't sure if I heard Mr. Stefan correctly. Did he say that they can or cannot afford to do the study? I didn't hear it correctly.
Ben, you want to respond?
So we can, it depends on the price of the study, Delegate. What my plea was to not add so many requirements that we end up with a $1 million study, which I think the legislature would sharpen their pencil and say, go back and think again. So as we add more and more specificity, we're also adding more and more cost to the total cost. As I said, I really think the three key issues are access, cost, and outcomes, and we're kind of playing around with it. To Robin's point, if additive matters if there's limited access currently. Cost matters if it's additive additional services that are simply in addition to. So I think we're fine with this, but my plea is no mas.
Well, I mean, I think the reason I was asking that because I see one section on page 13, the very bottom says healthcare service of which telehealth can substitute for in-person while maintaining the standard of care. I mean, how deep of a dive the commission would have to go or to do the study to actually find out if, how effective telehealth versus, and patient monitoring and behavioral health versus non-telehealth, like how deep of a study? I guess it doesn't say, but to your point, we don't want to make that study like burdensome, but obviously we want to make sure that it is working.
So, right off the top of my head, I would say this to you, that we're probably going to, Maryland is really pretty far out in front. I wouldn't say we are first, but we're moving ahead in terms of considering how we make some of these modalities permanent. But CMS, by comparison, is saying we want to look at services on a case-by-case basis to determine whether they are equivalent in effectiveness, whether delivered on a in-person versus telehealth basis. So we would probably look to other organizations that have more resources or different resources to get some information. In some cases, we're going to be having to do something original, but we would look to established standards that are already being developed, Delegate, if that helps.
Thank you. No, that does help a lot. I appreciate it. Thank you, Madam Chairman.
Thank you, Delegate Saab. Okay, so Robin, did you have another comment? No, just a raised hand. Rachel.
Hi, yes, thank you, Delegate Collison. My comment's unrelated to the study, so I hope I don't I don't want to jump into the middle of the conversation, but I wanted to double check a couple of things before I went back to something else. On page 6, you had talked about the proposal to change the definition of telehealth, specifically to talk about practitioners being licensed and it being a billable service. And I wanted to double check with a couple of my folks. Right now, CMS has approved for our Medicaid waivers and some of our carved out programs to have services be provided through audio only and video telehealth. This includes case management and care coordination. So this would include DDA's waivers, our REM program, our autism waiver. That's all safely being done through audio and video telehealth. Not all of these programs require that service be provided by a licensed healthcare practitioner. So under the Medicaid definition, if we limited it to HealthX license or certificate, a lot of those services would then be excluded under Medicaid. So I'm happy to work on any language to kind of close that loophole.
Okay, thanks. Yeah, let's talk about that. Evan Hoffman.
Hi, Delegate Collison. I'm looking at the study and the way it looks at remote patient monitoring, and I just want to make sure that the way I'm reading it, it looks to limit the scope of the study to remote patient monitoring for those with behavioral health disorders only. And so I just wanted to point that out because the main use cases for remote patient monitoring across the country are for patients with chronic illnesses and also for patients with acute conditions leaving the hospital as well.
Got it. Yeah, we can fix that. Delegate Mondari.
Yeah, thank you, Madam Chair. I don't know how much time we have since we are working to improve this bill. I have a couple of questions, like pretty much would answer that question, I believe. On page 8 and 9, we are talking about the report. I like the idea of the report, but is there any survey that patient satisfaction will be included, whether they will like the service or not? That's one. And another one is like, I would like to make sure that when the use of telehealth and opt-in, when we obtain verbal or written consent from the patient for the use of telehealth as an acceptable mode of delivering healthcare system for their patient protections. And it does not preclude a patient from receiving in person. Some of them might like that one. And all the confidentiality of healthcare information remain intact in this telehealth bill as well. And then patient under the Department of Correctional and Rehab facility, I don't think they can get this telehealth service, and it is mentioned there. Just a couple of suggestions.
We will take them under advisement as we work on it. Okay.
Thank you.
Ben Steffen.
Awesome. Sorry, my hand is still up.
Hand is still up. Okay. I want to thank you all very, very much for your engagement in this and reading this through and coming back with real suggestions. We'll take your comments, thoughts, ideas. If you have language that you want us to specifically look at to address some of the ideas that came up today, please send them to us. We will try to have something ready for you to look at with a potential vote on Tuesday. I don't guarantee that, depending upon, how far we get on Tuesday. But this is one of the most important bills that we're going to pass this session. So we want to make sure that it's right. And I really appreciate all of your time and energy on this. Know that it will be on the agenda on the Tuesday meeting, which is February 23rd. With Jen, did you have another question or comment?
I know everyone wants to go, Bonnie, so I'll be really quick. This is more clarification. The last section of the bill, which is section 6 now, I just want to clarify, I think that this sunsets the reimbursement rate in 2 years. And I think that was the intent, but just wondering if we could confirm that. It's just the very last section of the
Right.
bill.
Yes, that's
Yeah,
what it is.
yeah, that's what it is.
Okay.
With knowing that we are going to have recommendations and fully expect a bill in January of 2023 that's going to address the full gamut of services and reimbursement.
Thank you.
Thank you. All right, thank you all very much. Have a safe, warm, and fun weekend. We'll see you all back on Monday.
Thank you.